Hi, my name is Shilpa Joel, and I am an internal medicine resident at Broward Health Medical Center, and I will be presenting a case of Sweet syndrome as a first presentation of acute myeloid leukemia. Now, Sweet syndrome is a disorder characterized by peripheral leukocytosis, fever, and the acute onset of tender erythematous plaques, which are histologically comprised of dense dermal neutrophilic infiltrates. SS is a relatively rare phenomenon in which some estimates quote an incidence of 2.7 cases per million people per year. In most individuals, SS occurs without any underlying disorder. Usually in this idiopathic form, affected individuals often endorse a preceding URI and associated extracutaneous manifestations such as arthritis, conjunctivitis, mucosal ulcerations, and proteinuria. Less often, SS is associated with underlying malignancy, most commonly with hematologic, myelodysplastic, myeloproliferative disorders, as well as in the setting of some solid tumors. Malignancy-associated SS comprises 15 to 20% of SS cases, in which acute myeloid leukemia is the most reported related malignancy. Sweet syndrome in patients with AML may show atypical clinical forms with an aggressive course. Now, we have a 69-year-old female with a medical history of hypertension who presents with a 3-day history of warm, painful erythematous nodules on her right upper arm. ROS was significant for subjective fevers, malaise, fatigue, dizziness, weight loss, myalgias, and constipation. Her physical exam was significant for just 2 deep red nodules along the right upper extremity. Initial differential diagnoses include non-purulent cellulitis, leukemia cutis, and disseminated cutaneous bacterial or fungal infection. The biopsies were obtained as well as lab studies and flow cytometry. Her initial CBC showed profound pancytopenia with WBCs of 406,000, hemoglobin 3.2, and platelets of 37,000. Her manual differential found 93% blasts in her peripheral blood. Oncology was consulted for suspected myeloid malignancy, and subsequent bone marrow biopsy confirmed a diagnosis of AML non-M3. So, because she was frail and given her underlying infection, she was not a great candidate for induction chemotherapy. And she was subsequently started on leukapheresis to control leukocytoclastic crisis. Histopathology from the punch biopsy showed dense, superficial, and deep perivascular periappendage leukemic blast infiltrates. Her superficial dermis revealed marked edema and neutrophil infiltrates and features a superimposed SS. Her SS improved significantly after receiving 1 week of pulse systemic IV corticosteroids plus daily topical tacrolimus ointment and Vaseline application. So, really, for SS, there is some diagnostic criteria that was founded in 1994. There's 2 major and 2 minor. The major criteria include abrupt onset of tender erythematous papules and predominant neutrophilic infiltrate in the dermis without leukocytoclastic vasculitis. Minor criteria include presence of a fever greater than 38 degrees Celsius, at least 2 of the 4 abnormal lab values, including a WBC greater than 8,000, neutrophils greater than 70,000, ESR of 20, and normally elevated CRP, and a condition associated with SS, and an excellent response to corticosteroid therapy. According to the above criteria, our patient met 2 major criteria and 4 minor criteria, including diagnosis of AML confirmed by bone marrow biopsy. The pathogenesis of SS is not clear, but may be hypersensitivity to underlying infectious, inflammatory, or malignant condition that stimulates the production of cytokines, including GCSF. As a result, neutrophils are activated and abnormally migrate into dermal tissues. Now, with respect to management, corticosteroids, as well as other agents such as potassium iodine or colchicine, are considered as first-line treatments. From this case, we are reminded that concerning cutaneous lesions should not be overlooked, and SS can present at various stages of malignancy, including before, after, or at the time of diagnosis, which suggests that the syndrome may appear as an indicator of underlying malignancy. Along with a high index of suspicion, skin biopsy and immunohistochemistry should be maintained to confirm the diagnosis, especially given the diverse and non-specific clinical presentation of associated skin lesions and the poor prognosis associated with extramedullary infiltration of the skin or subcutaneous tissue by leukemic cells.